Hi, good afternoon. Thank you, Sages, for the opportunity to present today. My name is Ryan Chin. I'm a PGY3 at Montefiore Medical Center in the Bronx, and I will be going over my project assessing outcomes in laparoscopic versus open surgical management of adhesive small bowel obstruction. I have no disclosures. As we know, small bowel obstructions are a common problem faced by general surgeons all over this country. For a scope of how common this problem is, a 2016 JAMA Surgery article identified SBO as the second most common reason for surgical admission in the United States. SBOs are not only common, but expensive. Also in 2016, SBO admissions and surgeries accounted for over $3 billion in healthcare expenditures. Currently, the recommended standard approach for operative management of SBO is a laparotomy. However, the most recent Bologna guideline suggests that laparoscopy may be safe in a select set of patients. The project was inspired by a discussion at Montefiore amongst our general surgeons as to the best approach for the surgical management. With that said, the purpose of our study was to assess post-operative outcomes based on open or small laparoscopic approach to surgical management of small bowel obstruction. This was a single institution retrospective cohort study that examined surgical SBO cases from June 2016 to December 2019. The primary outcome of this study was return of bowel function, as defined by the restarting of a regular diet postoperatively defined in the chart. Our secondary outcomes can be seen here. Inclusion criteria for the study was patients over the age of 18 admitted to the hospital with a primary diagnosis of small bowel obstruction who also underwent a diagnostic laparoscopy or exploratory laparotomy during the same admission. Operative outcomes were analyzed only based on the index operation. Exclusion criteria included incarcerated or strangulated hernias, radiation enteritis, active inflammatory bowel disease, obstructions associated with bariatric surgery, other internal hernias, and no obstruction identified during exploration. We performed a head-to-head analysis of the outcomes of interest for all open and laparoscopic cases. The same outcomes were then subdivided into cases involving bowel resection and those that did not. Within the data set, surgeons were classified into Group A if they performed more than 10 operations during the study period. We then performed a subgroup analysis of surgeons within Group A by classifying them as laparoscopic preferred, or those who performed greater than 40% of their cases lap, or open preferred for those who performed less than 40% of their cases lap. We got this 40% number because the average number of laparoscopic cases performed in our cohort was 39%. The primary and secondary outcomes were then addressed within these two subgroups and compared directly. There were a total of 279 patients in our cohort, with 170 in the open group and 109 in the laparoscopic group. The characteristics of the patients showed no significant difference. Of note, there was no difference in age, BMI, Charlson Comorbidity Index, or peritonitis on pre-op exam or CT findings requiring emergency surgery. This table compares post-operative outcomes for the laparoscopic versus open cases for the entire cohort. The most notable points here are a median return of bowel function of 4 days for the lap group and a median of 6 for the open. Of note, the length of stay for laparoscopic cases was also shorter at a median of 8 days compared to 13 days for the open. We found similar results when stratifying the laparoscopic cases for bowel resection. When no bowel was resected, we found a significantly shorter return of bowel function, length of stay, and number of surgical site infections. When bowel was resected, the laparoscopic group still showed a shorter return of bowel function but did not achieve statistical significance. However, it does show a significantly shorter length of stay. I also want to highlight the significantly lower rate of reoperation in this group, with only 3 cases in the laparoscopic group versus 22 in the open. And while not statistically significant, we also saw a notably lower 30-day mortality and readmission rate in this group as seen here. We performed a separate analysis of the laparoscopic cases that were converted to open. There were a total of 51 cases that were converted to a laparotomy. In regards to our primary outcome, the median return of bowel function was 5 days. The median length of stay amongst these cases was 13 days. I also want to highlight that 51% of these cases involved a bowel resection, and 9.8% of these cases were also associated with a documented intraoperative complication. Next, I will review our findings when comparing the open preferred and laparoscopic preferred surgeons. This table briefly reviews the preoperative characteristics of patients in each group, showing no statistically significant difference in any of the characteristics. We then repeated the analysis of postoperative outcomes in the laparoscopic and open cases within each group. In the open cases, we found no statistical significant difference in outcomes between the groups, and there was no real identifiable clinical trends. However, we noticed an important clinical trend when comparing laparoscopic cases between these two groups. In the lap preferred group, there were a median of 0 30-day mortalities when resecting bowel laparoscopically, and a median of just 1 reoperation, 1 readmission retrospectively, but we were not able to achieve significance due to a small sample size. So the results of this study corroborate previous findings on laparoscopic management of small bowel obstruction, showing a shorter return of bowel function and length of stay. However, where this study differs is the selection of patients for laparoscopy. The laparoscopic preferred surgeons showed similar patient characteristics to the open group, suggesting that the choice of approach may be more related to surgeon comfort or training rather than the actual patient themselves. Furthermore, these groups showed overall similar outcomes without statistical difference. However, improved outcomes after bowel resection, including a median of 0 30-day mortality, suggests a notable clinical significance. Laparoscopic preferred surgeons may have a lower threshold to use laparoscopy on the classic sicker patient, which may explain the slightly high rate of mortality, readmission, and reoperation when not resecting bowel. The limitation of this study includes that it was a single-center trial with a retrospective approach and a relatively small sample size. We're currently using the same database to generate a cost analysis and to investigate risk factors involved with postoperative complications, prolonged length of stay, and laparoscopic cases converted to open. So in conclusion, a laparoscopic approach for surgical management for small bowel obstruction is both safe and effective. In fact, this approach shows overall superior outcomes to an open approach, and all uncomplicated cases may start with a laparoscopic approach. But the approach is more based on surgeon preference rather than patient characteristics. I'd be happy to take any questions at this time.